right, everybody. So we will get started. I'll just ask everybody, if you're not speaking, to please mute your computer line or mute your phone if that's what you're calling in on. That would be fantastic. For those of you who I haven't had the opportunity to meet, my name is Nicole Lindahl, and I work at Algoma Public Health as part of our emergency management program. And as part of that, I work as a liaison with the municipalities across the district, which has certainly been quite busy during the pandemic. That's for sure. I'd like to thank everybody so much for coming this evening on the beautiful Wednesday evening that we have, and taking some time in order to watch a presentation that we have on vaccines, as well as do some questions and answers. This is just a reminder that this meeting that we're having, this town hall, is in addition to the regional meetings that we will have each week moving forward as well for vaccine planning. And CEMCs are invited to those meetings that we're having weekly regionally in order to ask operational questions as well, and ask questions and discuss the vaccine planning process there as well. So without any further ado, I'm going to pass the floor off to Dr. Celeste Lowe, who's a public health physician at Algoma Public Health, and she's going to be our MC and our moderator this evening. Dr. Lowe?
Thank you. Good evening, everyone. Welcome to this evening's virtual town hall on COVID-19 vaccines. After our presentation, we'll have an opportunity for a question and answer session. You can submit your question in the chat box. You can also raise your hand, and once I call your name, you can unmute and ask your question. We have also received some questions in advance that we will get to. Now, I would like to introduce Dr. Lucas Castellani. Dr. Castellani is the Medical Director, Infection Prevention and Control with the Sioux Area Hospital. He will be giving an overview of the COVID-19 vaccines and their safety.
Thanks, Dr. Lowe. Thanks for having me, everyone. I hope everyone can see and hear me okay. I'm just going to share my screen now. If you bear with me. All right, and we'll go into show this now. Good. So thank you for having me today. So hopefully we can talk a little bit about COVID. Not that everyone's probably not a bit tired of it, I'm sure, but I think this is the time more than ever that we need to, dig our heels in and really work towards, achieving some good initiative and good success in managing this pandemic. So we'll talk a bit about the vaccine today. I do have kids that are at home with me, so if you hear little voices in the background, that's them, and we can enjoy their noises as we talk about COVID vaccines as well. So I do have a bit of a conflict of interest, only in that I work with a group of physicians that we're working on an app called Community Pass, and it does a little bit of stuff revolving around the pandemic. So just to make note of that, but otherwise nothing else. So what we're going to do today or this evening, I should say, is we're going to talk a little bit about COVID-19, not too long, but mostly what makes COVID scary. And then the big chunk of time will be the vaccines, in particular mRNA vaccines, as that's what's available at this time, and then the development process of vaccine. And I'm going to do a bit of Q&A before we do the actual Q&A afterwards. So in general, COVID-19, as most of you are aware, is a virus, not unlike many viruses that circulate and cause respiratory or sort of, infections like the common cold or even like the flu. This one's different, obviously, in the sense that it is more severe, actually a lot more severe, so depending on the studies you read, anywhere from 3 to 10 times more severe than something like influenza. And if you knew me before the pandemic, you'd know I spent a lot of time focusing on preparedness for influenza because of how scary that virus is, and this is a lot more serious. The virus, as we see it, starts sort of follows a course where if you are infected or do come in contact, it may cause infection, of which the virus will start to replicate inside you and may cause you to have some symptoms. And as the virus replicates more and more, the illness may become more severe. And at some point you may have, if you notice in the middle of the slide, there's a crossover of this viral replication to inflammation. So you may have an overabundance of your own inflammatory response. And that's typically the time point when things start to get a lot worse for individuals. Now, it wouldn't be, it wouldn't be a COVID talk without talking a little bit about asymptomatic and pre-symptomatic transmission. It's important to note that this virus, probably not unlike other viruses, but we're characterizing this more so, it can actually spread from person to person without the individual having any idea that they have the virus. So they don't have any symptoms whatsoever. And that is what we determined or we deem as asymptomatic transmission. It's very difficult early on in the time that you have the virus to know whether or not you have asymptomatic or pre-symptomatic infection. Pre-symptomatic just means you haven't developed those symptoms yet, but you're going to have those symptoms. So I think just important to delineate that piece, and that's what's made it very difficult for various public health organizations and governments to get a good handle on this virus, because it's of this asymptomatic and pre-symptomatic spread. The scary part about COVID, though, is this, and I'm sure most of you have seen pictures and have heard stories about individuals that can look okay one day and the next day become very unwell and end up in the ICU. And most of us probably at this point in time have had some degree of separation from some individuals who have become quite unwell with this virus. And so it's important to note that this is a very scary piece about the virus, that people can end up in the intensive care unit and even die from it. But to me, actually, the biggest and most troublesome piece about the pandemic is this piece, and some people refer to it as long haulers, other people refer to it as post-COVID syndrome. These are the individuals who get COVID and they recover, but for days, weeks, months, potentially years later, will develop symptoms that sort of debilitate them and don't allow them to function normally in their day-to-day life. So, for example, I'm going to point to the bottom corner of this brain fog piece. Is probably one of the hardest things to articulate in medicine, and I don't think I've seen a good document on what that means. But I do know what it means for patients, because I see a lot of patients, and I even saw them before COVID come in and describe what they refer to as brain fog. And I've actually been looking after, through virtual care, some of our positive COVID patients along the way. And it's not infrequent that I will hear this concept of brain fog. And it's people that just can't function like they normally could. It's like they're walking through a fog, with lack of a better way to describe it. But that's not all. I mean, they have fatigue and headaches and all sorts of potential symptoms. And when I can't tell them, even though they ask, how long is this going to last for, doc? And I can't tell them how long it's going to last, because there's no good science to tell you that. And I could tell you a good proportion of people with COVID do develop these symptoms. So it's not uncommon. It's actually more common than you would think. But this is the vaccine talk, and I think this is a really neat slide that I saw in Twitter. I think it was on Twitter one day. I thought it was kind of funny, and it shows you you don't really need a good stats. You don't need a good statistician to help you with, and this just shows you that in the vaccine group in this sort of study here, they didn't develop any COVID, because this, as you go up, you'll show more COVID cases, whereas the placebo group obviously got more. So this shows you don't really need a degree to show that, to understand in this graph that the vaccine group did. And this is actually the COVID vaccines in particular, the ones that we have available to us here. So we're going to talk a little bit about the particular COVID vaccine, so people are familiar with what that is. So there is the Pfizer vaccine, which is an mRNA vaccine, like the Moderna, which we're going to talk about as well. So the Pfizer vaccine, or I should say Pfizer and BioNTech, which is actually a German company who designed or discovered the vaccine, and then Pfizer sort of purchased it, and together they're working to develop and to produce. So this is approved for age 16 years and older. It has a 95% efficacy. And when you say in preventing COVID-19 infection, what they're really referring to is preventing symptomatic COVID-19 infection. So it's very good at preventing you from getting symptoms from COVID. It also reduces infection severity, and I believe there haven't been anyone that have had severe infection or died from COVID after receiving the vaccine. There are 2 doses, and they're given at about day 0 or the first day, and then day 21 to 28 apart. The tricky part about the Pfizer vaccine, as you've probably heard in the media, is it has to be stored at minus 80 degrees, which sort of is a tricky piece in terms of the the distribution, getting it from where they manufacture it all the way to the patient's arms. Oops. So a little bit more about the studies, just for your own understanding and comfort. Each trial, and this is the same for Moderna, which I'll show you in a second, there are 44,000 participants. That's a big study. So if you follow medicine and studies in medicine, 44,000 is a lot of individuals. There aren't many studies that have more, or clinical trials, I should say, that have more patients than that. That's as big as they get, kind of thing. And they were pretty disperse in terms of the types of patients they had. They had patients from all across the boards, young, old, all sorts of racial and ethnic backgrounds, all sorts of underlying diseases, including even HIV. And the only thing that they didn't have, which is unfortunate, was patients who were pregnant and younger patients. And what they were looking for was that endpoint, as I said, about symptomatic infection or severe infection. So side effects, this is the crux and what we might hear a lot about in the media as we unravel or unroll these vaccinations more commonly. And the side effects are very common. In comparison to many other treatments we hear, you're going to hear a lot of side effects with the vaccine. So but the side effects are manageable, and they're actually they're fairly, they're not too bad. If most of the people that I've spoken with who have had those side effects, if they're telling the truth, they're not too bad. The most common one would be pain at the injection site, but there's everything from fatigue or headache. If anyone has had some sort of mild reaction after they've had the flu shot or any other vaccine, it's fairly similar. I'd say if anyone's had a shingles vaccine, the more recent, the Shingrix vaccine, it would be quite similar to that, if not even maybe less significant than that reaction. Some individuals will develop a fever and will feel almost like they have COVID, but that means that the vaccine's probably doing its job, because it's allowing your immune system. It means the immune system saying, "Hey, the vaccine is here. It's like the virus. We're going to create a response," and that means it's probably working. Moderna is the other vaccine. It's really for 18 years of age and older, and its efficacy is pretty similar, 94.1%. And it, again, is also for symptomatic COVID infection, reducing infection severity. So, do people actually notice that they have COVID once they have this vaccine? And it's it's the same. It's pretty much 2 doses that are at day 0 and day 28 apart. The storage is a little bit easier, and that's sort of why things have been a bit better in terms of distribution. In terms of the study, again, 30,000 clinical trial participants. That's, again, quite a large trial, pretty good representation of multiple populations in there. So lots of people were in the study. It wasn't just one group of people. But the only other side point, I guess I should point out at the bottom here, in participants who are 65 years in age and older, there may have been a trend towards less efficacy in that group. But that's not uncommon or unexpected, as we know that elderly patients or patients, as you get more experienced of age, your immune system it tends to not have as big of a response to vaccines. It doesn't mean they don't work at all. It just means the response is not as significant. And again, like the Pfizer vaccine, the symptoms or the side effects, I should say, are fairly similar. There isn't really much else to note about that. So most of you are wondering, what's all this talk about mRNA vaccines? What are these things? I don't understand. You've probably heard various rumors about them. You've heard all sorts of things. But like any vaccine, the job of the vaccine is to tell your immune system that, or at least trick your immune system to think that you have the infection in front of you. And so it creates a response to that vaccine, just like it would to the infection itself. And so that if you do actually come into contact with that infection, your immune system will know what to do because it's seen it before. And so the way the mRNA vaccine is similar to other vaccines. The way the mRNA vaccine works is it sort of gets taken up by some of your immune cells, and that mRNA is part of the building blocks in your cell. And what happens is your cell sees this material. It's what I call a transient, or it's almost like a type of genetic material that's really, it's there and gone, and it's an in-betweener. It's the in-between genetic material in making things. And so it gets this message. It's a message to tell your cells to make these proteins. And those proteins are the things that go on the outside of the cell. And after it makes those proteins and they go on the outside of the cell, the rest of your immune cells say, hey, oh, it looks like I have COVID. And so it creates antibodies to it. So it's similar to other vaccines who will do similar things and tell your cells to make proteins on them that look like you're actually infected when you're not, and it tricks them into doing that. So that's it's fairly similar in a nutshell. But just to simplify things a little more, went backwards. I'm going to play a little video, and I hope you guys can see this okay, but it's essentially a video on the mRNA vaccines. All right. So it's important to know that we can all have confidence in the vaccines themselves, and there's a lot of concern that corners were cut and things happened too quickly. But let me assure you all that these vaccines are very safe and they're quite effective. And interestingly, I would say, the reason they were so quick to come to fruition was because every effort in the whole globe was trying to get them to fruition. Other things were put on hold so that these studies could happen. Other things were put on hold so that these studies could be then reviewed at all the health agencies. And so I feel fairly confident that not only did they go through the same rigor as all studies do, but maybe even more, because all eyes were on them and all the regulatory bodies and everyone were working towards this day and night. So side effects, we already touched on it a bit. Side effects are common. It's very clear, but they aren't serious side effects and they're nothing to really be concerned about. Most commonly, it's things like headaches, and some people do develop fatigue and fever. Most commonly, it's pain at the injection site, but they are kind of signs that the vaccine's working, so it's not necessarily a bad thing. And most of them are manageable. So how long will the vaccine work for? So unfortunately, we don't have enough long-term data to tell us. Certainly, it seems likely that, based on the studies, it's going to work for a few months. But how long, we don't know. We know natural immunity from viruses like SARS-CoV-2 or the COVID causing virus can last, an immune system can last for years, for upwards of 2 years. But it's difficult to know, and unfortunately these days we're seeing these variants of concern, which are essentially changes, or multiple changes I should say, to the virus's genes that allow it to potentially evade our immune system. And if that happens, we don't know whether or not the vaccines will work the same or last as long. But it's kind of a race against time right now, because the faster we can all follow the public health recommendations, and the faster we can all get vaccinated, the more likely that those variants will become less of an issue, because the virus won't have time to evade our immune system, because you need a lot of virus replicating, meaning becoming more and more virus. You need a lot of that to have these variants of concern. But to answer this question, that we don't really know how long. And what are the long-term side effects of vaccines? Well, that unfortunately we can't say with certainty, because these vaccines have only been in place for a short period of time. That said, any person who has had this vaccine thus far, we haven't seen any trends towards long-term side effects. The clear thing to point, though, is we don't expect anything to happen that's much different than other vaccines. And most other vaccines don't really have long-term sequelae or side effects. In fact, you would argue the side effects or long-term sequelae, as I mentioned earlier, from COVID itself would be much more severe and problematic. And in fact, most times when folks have felt that maybe there is a side effect that's long-term from another vaccine, it seems to be refuted based on big, large longitudinal studies, which are just studies that look at people over a long period of time and really try and figure out whether or not these could have caused that. So what about immunocompromised individuals? So some people may have cancer and on chemotherapy. Some people may have certain autoimmune type diseases and need some medications to reduce their immune response. For various reasons, some people are immunocompromised. And the question is it safe to use the vaccine? And I would say it is safe based on what we are apprised of as of right now. But that said, we don't know 100%. And so the most important thing, if you're concerned, you should speak with your physician or your doctor who's providing those immunosuppressing medications, or who cares for you with your immunosuppressing or suppressed condition, and chat with them about this. But for the most part, we suspect it would be safe. In terms of efficacy, just like as people get more experienced of age, we suspect that the vaccine itself may not work as well in these individuals, which is not unexpected, but it still is worthwhile, because the protection against the virus is important. So any protection is helpful. What about pregnancy and breastfeeding? This, I say, is really up to the individual, just like the immunocompromised patient. There are multiple societies out there that look at patients who are pregnant and breastfeeding, and they have, for the most part, come out and recommended for the vaccine, because they feel that the vaccine is important to prevent hospitalization and death from COVID-19, which is actually probably more common and more severe in patients who are pregnant and breastfeeding. That said, there were no patients that were pregnant or breastfeeding in the studies. And so if you are concerned or have questions, it's totally reasonable to have a conversation with your doctor and do some more reading and research on this, because it's really your decision based on your appreciation of the risks and benefits of this. How do I treat the side effects of the vaccine? So the important thing is, based on prior studies looking at other vaccines, we do know that there probably is some reduction in immune response if you have taken a medication such as Tylenol or ibuprofen prior to getting vaccinated, meaning the vaccine might not work as well if say you took Tylenol beforehand to try and prevent that sore arm. We see that in other vaccine studies. We haven't really had the same type of evidence or literature in COVID, but we suspect it could be the same. And so most societies are recommending against that. Now, you could consider something like Tylenol or Advil or ibuprofen if your symptoms weren't manageable after you were vaccinated. So say you had the vaccine and the day later or within the next 12 to 24 hours, you had such severe arm pain that you couldn't manage, it definitely would be worthwhile to try something to help with your symptoms. But whether or not you take it, but I certainly would not recommend pre-medicating, if you will. For those of you who are already on medications like Tylenol or ibuprofen or things like that ahead of time, it's reasonable to chat with your doctor about holding those beforehand if you feel like that's something that you could do. But oftentimes you don't want to cause a flare of your underlying disease because that could actually prevent you from wanting to go get your vaccine or prevent you from feeling well when you're going into the vaccine. And so we wouldn't want that either. So important to speak with your provider about that. Will the vaccine work against the new variant or virus strains? So it seems as of right now that it should work against the, I'm calling it the UK variant here, but we should be more precise and not name it based on geography. So it's the B117. So based on, so it seems that it should work against the B117. However, there are other emerging strains, the B1351 from South Africa, where it was first noted, and the P1, we don't quite know. I believe there was some work done by Moderna and Pfizer to suggest that it should work, and we should have enough levels of antibodies that it should work reasonably well, but we haven't seen the evidence for this. And future vaccine modifications, so changes to the vaccine may be required depending on how things go with time. So without further ado, I guess we'll open it up to questions if everyone's comfortable with that. And I will try and open up the chat box so I can see that also.
Thank you, Dr. Castellani. I'm just looking at if there's any hands for questions, and I don't see any.
So Dr. Lowe, I'm just going to, before we move on, I got a question sent to me, and I'm just going to answer if that's okay.
Yes.
So the person asked, can someone who has had the vaccine, who are on immunosuppressants, be tested afterwards to see if they have antibodies? So the short answer is no. The long answer is we don't quite have a good handle on what antibodies mean after you've been vaccinated and which antibody tests would be the right ones. There is good work in this space and there is a lot of suggestion of what would be right, but there's no good guidance and good practice to recommend. So I would say just keep your ear to the space and hopefully there'll be something in the future, but there's really nothing at this time to suggest how to move forward for this.
Thank you, Dr. Castellani. Mike Garside has a question. And the question is, what is the estimated time of arrival of availability for our communities? I'm thinking that means what's the approximate timeline for vaccine availability to our communities?
So I think I have to turf this question over to Dr. Liu or Dr. Lowe, even if either of them can provide some insight or anyone else from APH.
I will happily receive the pass. Thank you, and thank you for the question. So maybe I'll give a broad overview of where we are at this moment in time. Our CEMCs continue to be invited in our weekly vaccine planning teleconferences. For those around the virtual room, Sault Ste. Marie's weekly meeting happens Monday afternoon. Elliott Lake and area happens Tuesday afternoon. Central and East Algoma happens Wednesday afternoon, and that was today, just earlier before this teleconference. And then North Algoma's is on Thursday our municipal CEMC partners are on those calls, and they are generally, and they've been happening since the first week of January, to make sure that we are in readiness to receive vaccines. So up until this point, there has been a shortage, and the only doses that we've been allocated were just enough to go into the arms of long-term care home residents and the residents and staff of First Nation elder care lodges. So this has happened and has been completed across the district. Those first doses have been into arms. What is happening is that not this week, but the following week, we will expect to ease from that shortage of supply. We will receive an allotment of second doses for residents, and then we will receive a shipment of Pfizer vaccine that will allow us to complete staff and essential caregivers of long-term care homes, and also start immunization in the highest risk healthcare workers. So that means that all 4 hospitals within the next couple of weeks, likely early March, would be able to start immunizing those highest risk healthcare workers, and the staff and essential caregivers of long-term care homes will also start receiving vaccine. In the subsequent weeks, we will be able to move down the priority list that has been determined by the ministry. And again, a memo was sent out over the weekend, as well as the guidance document on prioritization. This has been disseminated to all vaccine planning partners, including CEMC. So if you'd like a copy of the gory details, they are there. We will also be providing a more detailed update on our website in the near future. So the answer to, when is it available in the communities? It has already been made available, but to certain groups, starting with long-term care, starting with highest risk healthcare workers in the hospitals. And then I would say, aiming for mid-March or later, depending on the arrival of doses, we'll be able to start adults 80 years and over in all communities as well. And the immunization of those folks is being heavily planned at this very moment. We are awaiting some finalization from the ministry of their IT solution. And in the meantime, we're making enumerations of these groups, working with primary care partners, estimating those patient populations, and then determining effective sites of immunization within each district. So most of these sites will be where people have been able to go and get their flu shots in the past. We will start with a few centralized sites just for purposes of efficiency and also logistics, because the 2 vaccines we have right now do need that ultra cold storage. And then again, as supply improves and as we're able to move vaccine more, we also have a group of folks who are planning to do mobile teams, because we know that some folks are homebound and need to have doses delivered to them. So it will be ramping up slowly but surely in the coming weeks.
Thank you, Dr. Liu. So before I read some of the questions submitted in advance, just wanted to make sure we're not missing any questions from anyone. If you want to raise your hand.
I can also answer Beverly's question.
Yes, so I will just read it out. How will people be contacted to get their vaccine? Like for seniors living in their own homes, will they have to call in or wait for a call?
That is a great question, Beverly, and we are in the process of working this out. I think the process might actually differ depending on, the community where you live in. Some communities have a longstanding EMR and booking system that they use, and they routinely call people, and others communities might have something set up where people are able to, self-serve, book themselves online, or call a number. So we're looking at collating all of this information once it's finalized with our primary care partners and putting it on our website. And we will absolutely be sure to disseminate this to all of our municipalities and CEMCs, because we know that where people get vaccine will depend on where they live. And absolutely we'll make sure that there's multiple ways for people to sign on.
Thank you, Dr. Liu. There's another question from Nancy about having whether you have a schedule for age ranges outside of 80 plus age group.
Yeah, for sure. So that will definitely depend on what we receive in terms of allocations of vaccine in the weeks following, March. At this point in time, we receive notification sometimes a few days in advance. Recently, it's been thankfully a week or two in advance, and that has been what we've been able to go on to plan. So for younger people, for frontline, essential workers like teachers and grocery store clerks, we know that a lot of those groups are in phase 2 of the provincial guidance. And again, it will depend on when we know doses are going to be available and local partners are going to be able to deliver those immunizations. So my kind of guess at this point, best guess, based on our numbers in our population, is that it might be springtime when more of the general population are able to get their immunizations after the majority of, highest priority folks like the elderly and high-risk healthcare workers are done.
Thank you, Dr. Liu. So I have a question for Dr. Castellani. If someone is allergic to thimerosal, can they still receive the mRNA vaccine?
Yeah, I mean, my understanding is there's no thimerosal in the COVID-19 in the mRNA vaccines. I don't think they're using that in their process of making the vaccine. Correct me if I'm wrong, please, Jen, if you know any differently. But I didn't see it on the vaccine list. I shouldn't share too much. My wife actually has an allergy to thimerosal, so I do look at these things closely. But yeah, I haven't seen that.
Thank you, Dr. Castellani. Another question for you is, what's your view on the vaccine effectiveness in regards to the variants, the multiple variants that have been identified?
Yeah, so efficacy against variants. I mean, I think this is a hot topic that I personally don't think we have the data to actually say with certainty anything. I mean, it seems that the B117, so the one that they're describing in the UK, the one that's probably the most circulated in North America and Canada right now, the one that when they talk about variants of concern, they're really talking about that one mostly. Asterisks. That one it seems to not affect as much. That said, the B1351, the one from South Africa, is probably affected, at least to some degree. I think I read something that said 6 times less effective. But that said, both Pfizer and Moderna did some closer looks at things, and they think that the antibody titers, meaning the immune response for individuals, will still be enough to develop an immune response. But how that actually plays out in the real world, in real life, is very difficult to know. And so it's probably an important point to mention right now that above all else, all the other public health recommendations stand, and they need to be followed to the T, because if we don't, then the virus circulates more, and the virus has more time to replicate, and it can create more variants of concern by creating more mutations. We saw the B117 in the UK on its own spontaneously developed that same mutation that the one in South Africa has. So these things can happen if we don't continue to follow all the good recommendations from our public health folks. So that's why it's important. So, but in terms of efficacy, time will tell. But keep watching the space.
Thank you, Dr. Castellani. And then I have a similar questions for Dr. Liu. In light of the concerns for the variants present, are there plans to ramp up the vaccine distribution? Or is there a supply issue?
Yeah, so at this point, by all the information that I've received from the province, the supply issue has been a February kind of issue, and it looks like that March will really be the, I believe the Prime Minister called it the big lift in terms of opening up of supply. We don't yet have confirmation of additional products of vaccine being approved. So for example, AstraZeneca is a vaccine that the UK has been distributing in large volumes with great success. And that is certainly a candidate for Health Canada approval. As soon as more products become approved, this could drastically ramp up our operation. So when I said earlier, I think spring might be a good time for opening up broader to the communities. This could very well happen if additional products are approved, because then we will have much larger volume of supply. Some of these products are going to be fridge stable and much more easier to handle. And in response to Sherry's question about pharmacies, this opening up of supply will also let additional immunizers come on board. So places like pharmacies, additional primary care clinics who don't have an ultra low freezer can then be able to store and administer as well. So that's certainly what we're hoping for at this stage, is that yes, March is going to see a ramp up now that we're out of the shortage, and hopefully as more product becomes available, an even faster ramp up. As we know, the variants are circulating and increasing in prevalence at this point. So very much want to keep pace and get folks immunized as quickly as possible. I think General Hillier's favorite phrase at this point is speed trumps perfection. So that is what we are aiming for as quickly as possible with every allotment that we get.
Thank you, Dr. Liu. So I have two part of this question. So maybe I'll get Dr. Castellani to answer the first part. Does one vaccine have a higher percentage of protection over the other one? And that if for example, the time interval between the two doses of vaccine, let's say with Moderna or Pfizer, is not follow within the 21 or 28 days time frame, how is it going to affect the effectiveness?
I think I know where they're going with this. So I think the question is, correct me if I'm wrong, please, whoever asked it. I think the question is, if you're getting, say, the Moderna vaccine, is that as good as Pfizer in the first 21 days to provide some protection until you get your next dose? And knowing that there's a delay in the vaccine coming into our country and our province, you actually may not get your second dose until a period after, sometimes 6 weeks, sometimes even longer in some places. I think in the UK, they're sometimes routinely vaccinating 12 weeks later for their second dose. So I think the question I'm guessing is one better than the other for that in-between period? And I think the answer is, I don't know. I suspect based on the studies that the curve looks very similar. So, but you can't really compare the two in that sense. And I don't think there's literature to suggest. I think they're similar enough. And I probably would take either one. So basically, I'd take whatever vaccine you can give me. And it is interesting that time period between, it was arbitrary, not arbitrarily, but they chose a period of time that they thought was reasonable to revaccinate someone with the booster at 21 or 28 days later. But there are some studies out there with other vaccines where we had to wait a bit longer, and that might actually even provide you with a little more protection. And there's some suggestion that doing the same with the COVID vaccines will work better. So I think time will tell in terms of all this evidence. I think for right now, just got to recommend getting the vaccine. And I apologize. It sounds like my dog is barking behind me in outside the room.
Thank you, Dr. Castellani. I'll just follow up with the Health Canada saying that they're imminently approving AstraZeneca and potentially the Janssen vaccines. If, let's say, by the time that they are eligible for the vaccinations, all four comes out, do you have recommendations of which one over the other, or do you advise just anyone that is available?
I would just get whatever vaccine is available personally. I think there's certainly some suggestion that some vaccines might prove to be more effective than others. I think the important point that we should make is, if you look, I can't remember if it was a meme or what it was that I saw the other day on Twitter, but they showed all the vaccines in the comparison. And although, yes, we do see, we have seen more or sort of less efficacy with some vaccines over others in terms of, the absolute number in terms of success. What we have seen, though, is no severe infections and no deaths in people who have been vaccinated. So I think it doesn't matter which vaccine you use, they all prevent severe illness and death. So that, I think, is very powerful on its own.
Thank you, Dr. Castellani. And this one, the second part of the question, I'll direct to Dr. Liu. Will I have the choice of which vaccine I prefer to be vaccinated with when it's time for my vaccination?
That is a great question. So I will say that at this time, there is very little choice available because there's only two. And usually at any given point in time, our inventory is really one or the other directed for priority groups. On the heels, to echo what Dr. Castellani said, at this point in time, I would say, whatever vaccine is available to me right now, as soon as I'm eligible, I would want to get that vaccine. Down the road, if there are, an abundance of supply and shots, it's conceivable that there could be multiple points of access, and you may be able to receive one product at one place and another product at another. Again, some of this is based on logistics, right? Some of these vaccines are only fridge stable for so long, and others are fridge stable all the time. So depending on location, there might be a difference in the product available. But ultimately, I wouldn't wait. If it were me, I'd want to get as many people in our communities immunized as quickly as we can, because only then can we actually achieve that community protection.
Thank you. I also have follow-up questions for you, Dr. Liu. It's about using community facility for mass vaccination. What is there, first of all, is there an expectation of using, for example, community halls for mass vaccination? And if so, what should the municipalities prepare for? For example, estimate day timeline, the different population that will get a vaccine.
Yeah, absolutely. So this is part of the conversations that we're actively having with our primary care partners. These are the folks who are going to be, the hero immunizers in our communities. And some of our municipalities may already have been tapped on the shoulder to use your premises, especially if we've used them in the past for things like immunization. So I would say that stay tuned. If you haven't yet been tapped on the shoulder, you may be, especially by your local family health team. And I would say, there are a number of considerations to look at when it comes to a mass immunization clinic. If it's going to be, the one major centralized site to churn through a large volume of people very efficiently, but also very safely. We still need to do that physical distancing piece. We want to make sure there's ample traffic control. So those are some of the considerations that are being held at this point when considering for these sites. And I notice Nicole has a hand up.
Yeah, if I could just briefly note as well, if for anybody who's wondering or asking a similar question, if you connect with your community emergency management coordinator in regards to this, they should have access to our Algoma COVID-19 immunization plan. And if you go to page 29 of that plan, there is information on what is needed for a mass immunization clinic. So if you're wondering if your community hall would even be fit to host a vaccine clinic and what would be needed, if you go and you have a look on page 29, just, even for curiosity about what we're going to need, those next 5 or 6 pages outline everything that would be needed there as well.
Thanks, Nicole. Nicole has heroically read through every single page of that giant plan. So I definitely encourage you to have a browse through if you like. What I'll also say is that you need not, it's not all or nothing. So some sites will be a major site and that will be a full-time immunization clinic, for months, for example. But we also might be interested in pop-up sites. There are some communities where just based on the small number of the population, it doesn't make sense to have, a large operation day after day, but we might have an intensive pop-up clinic there for specified dates. And so we've already received, offers from a number of community organizations offering up places for such purposes. So I think that there has been a tremendous amount of goodwill and support from local partners, and there will be ample opportunity for us to be able to take advantage and work with our primary care immunizers to be able to use them.
Thank you, Dr. Liu. The next question is for Dr. Castellani. Can you mix a vaccine? For example, if you get first shot with Pfizer and then no Pfizer is available within the recommended time frame, would you be able to receive a shot of Moderna or AstraZeneca?
Oh, sorry, I realized I was on mute. I think the short answer, I think that probably is the answer, but how that all unfolds and is going to be, it's too complicated to sort of even speculate, because we really don't have studies in that regard. So to be a purist from a medicine point of view, there's no studies to say what to do. From a theoretical point of view, sure, why wouldn't it work? I mean, interestingly, the Sputnik trial, which is the vaccine in Russia, they actually use two different sort of things to tag the vaccine onto, if you will. So they're different viruses that we use for other types of vaccines, and they use two different viruses to give you a slightly different immune response. And so there's some work out there in this space, and so I suspect it probably would work, but we don't know. The evidence isn't there. And then to speculate how it would be rolled out, I think that's even a bit of a leap. But again, I keep saying this: watch the space. But I feel like that's kind of the theme during the pandemic for these very well thought through and very reasonable questions that we just don't have the evidence or literature to point in the right direction yet. And so if the purist in me says no, but the theoretical person in me says, yeah, probably, based on what I know about vaccines, but it's hard to know. And I suspect, Jen, if you could comment from the practical side of things, it seems like it would be pretty tricky.
Yeah, for sure. I think that especially, before everyone has a chance to get one shot, it'll be doubtful that folks will be able to get multiple. And I would say from a rollout standpoint, we are carefully keeping an eye on inventory so that folks are able to get their second dose within the recommended interval. However, we know that, sometimes people are not available. This happens all the time with childhood vaccinations. People travel, people get sick, people forget. And shots get delayed. And so, from a physiological and immunological standpoint, delaying booster shots is actually, not a barrier for the vaccine to be working. Getting it too early might be a problem and you might have to restart, but delayed boosters are actually not usually a problem. So, from that standpoint, a delay of that, prime recommended interval is not a problematic. You can still get that same shot when you're able to do so.
Thank you, Dr. Liu. The next question for Dr. Castellani. Are there clinical studies that will end soon that will let us know if children under 16 may receive vaccine?
Yeah, I think there are. I don't know when they're ending. I don't actually have the exact time in my mind. I mean, the problem is, even if they ended tomorrow, it'd still take a bit of time to go through the regulatory process. But yeah, they've been doing those studies since the other studies sort of ended, if you will, once they showed safety in the older population. The difference is with kids, they tend to have a little bit different immune responses. They're not like, as I think I've said in other chats, they're not like little adults. They do have a slightly different immune response to things. It's why our series of vaccination in younger populations are different in older populations. And so we just don't know how that'll unfold. But I think, but yeah, I'm thinking soon we should get some information. Kids under 16, I believe the trial right now is, if I'm not mistaken, is 10 to 16, but I correct me if I'm wrong, if someone knows exactly. I can't remember. I think it's not quite as young as you would hope, but I think it's in the 10 to 16 kind of age group.
Thank you, Dr. Castellani. The next question is for Dr. Liu. it is asking if a municipality is required to offer a particular facility for vaccination, for example, arena where it needs some advance preparation, how much advance notice would be provided to the community so it may prep and set up the proposed area?
Sure. So I just want to reassure everyone that we're not going to commandeer any spaces, even though there is a general at the top of this. We are not the military, and we have been working very closely with primary care partners. So, at this point, we will give you certainly advance notice if we're interested, or if local partners are interested in a particular site. And the planning that will happen as quickly as possible, and certainly with the agreement and participation of that municipality. We're trying to do this work now in preparation for, potentially, as I said, springtime opening up, because this is the first time we've gotten an indication that doses will come. I also got an additional question through my chat, which is to ask, does APH have the ability to prioritize the vaccine distribution, or is it totally ministry driven? Certainly some of our communities are different than others. Some have a lot more older populations, some might be more remote. So I would say that the ministry drives the prioritization sequence, and we do have to follow the sequencing as laid out by the ministry. However, we know that there are larger groups in certain geographic areas of certain priority populations. So, if Sioux Area Hospital has a large number of healthcare workers, or Elliott Lake has a large number of seniors, we want to make sure that the local immunizers in those geographies are immunizing as quickly as they can and are provided with that supply as efficiently as possible, as soon as the allocation comes to Algoma Public Health from the province, that we would be disseminating it to all of our immunizers. So I think that the priority groups within each geographic catchment area will receive vaccine as quickly as it is being made available to them. And who that looks like might differ a little bit from community to community, because we're not going to wait, for one priority group to be finished in one community before moving on to the next in another. Every community looks a little bit different, and we're going to move vaccine as quickly as immunizers can get shots into arms.
Thank you, Dr. Liu. And then I have a bit of follow-up question about logistics of the vaccine rollout. One part of it is that whether in smaller municipalities, if there is any potential for small clinic instead of like a one massive mass immunization clinic, say in Sault Ste. Marie, is there opportunity to offer like small vaccine clinic in just like a township, so people can stay local? Second part is if when the vaccine is rolled out to like everyone in phase 3, are you planning to offer by age group or first come first serve for some kind of sequence so that there would be more order in the vaccine rollout?
For sure. Yeah. So the first question around, will small communities be able to have kind of local points of immunization? And that is our greatest hope, that yes, eventually, especially when we get more products that are movable and fridge stable, that there will be points of immunization across the district, just like for flu. At the very beginning, it will be primarily at centralized locations. However, we are working very closely with primary care providers to make sure that, within a reasonable distance, there is a site for immunization for the, priority 80-plus-year-olds and the priority healthcare workers. So that's where we are going with that piece. And then the second question, sorry, Dr. Lowe, I'm trying to
Yes,
call?
it's about when the vaccine when the vaccine rollout is in phase 3, where everyone can, any Ontarian is wishing to get the vaccine can get it. What sequence will you be rolling out the vaccine, or kind of by first come, first serve, by appointment, or by age group?
Yeah, so my hope is that by the time we get to phase 3, that will mean that we have completed everyone in those high priority groups who got to be first in line, and that it will be very much an effort, no longer, to get arms quickly as possible, but really to hit the stragglers, to get your friend and get your neighbor and get your relative who've been kind of humming and hawing about it, and get them to get in line and finish those shots. We see this with flu every year, actually, especially at APH. The first couple of months, everyone who's eager is flooding our phone lines. We are packed and we are booked, and then it just kind of tapers off. And it doesn't mean that everyone's been immunized. It just means that all the eager folks are done. And now we're doing the hard work of bringing folks in to get them to immunize more. So at that point in time, I'm hoping that people can just walk into a pharmacy and get immunized, or they can self-schedule themselves online. I think at that point in time, the supply will exceed demand, and our work as public health and our healthcare provider partners, and hopefully you as municipalities, will be to look at our numbers across Algoma and say, hey, how can we get this up to get to a coverage where we have community protection?
Thank you, Dr. Liu. The last question is for Dr. Castellani. Dr. Castellani, what do you foresee as the percentage that will require, like in the population, to receive the vaccine in order for us to have some sense of normalcy?
I wish I had the answer for that one. I think the epidemiologists could calculate some sort of number that would lead you to a herd immunity. I don't pretend to be an epidemiologist, but with the vaccine, if we were using only ones that had a 90-some% efficacy, you probably would need, 60, 70% of people to have the vaccine to see herd immunity. But the tricky piece is the variants of concern come into the picture, and they may reduce efficacy. Our population is not all going to be folks that were in the clinical trial, so efficacy is going to be different in the actual real world. And there's going to be probably more people than we recognize that don't get vaccinated. And then there's the piece that vaccines only work for a period of time, and probably it'll be the same as every other vaccine, where they may wane with time, meaning our immune system might not be there as well as it was at the beginning. So I think it's a TBD, and I don't think I can give a good answer. My hope that I keep saying this and keep pushing forward. My hope is that if everyone follows public health guidelines, we get the vaccine out as they are anticipating by September. It's all involved. We could see some normalcy by next year or around springtime. That's my hope. If it comes sooner, amazing. But I really think it's going to take some time, and we may see a bit of a surge or a few more surges along the way, depending on how the population does. So a lot of this is all speculative, and so I wish I could give you a concrete answer, but I don't think anyone could give you a good concrete answer. If they can, you probably want to question them. But thanks. It's a good question.
Thank you, Dr. Castellani. The next question is for Dr. Liu. Are municipalities able to place orders to look after their rate payers at time of stage 3?
Place orders as in kind of hold allotments of vaccine for your specific municipal ratepayers? Right.
Yes.
So, quite frankly, I don't think that's going to be necessary. As I mentioned before, right now, demand exceeds supply, and very quickly, because the Canadian government has ordered, enough vaccine for every Canadian of each product, essentially. I think we will reach a stage where the supply is going to exceed demand. So I don't think that there's any need to reserve doses. Doses will be made available to all sites that are providing immunizations when we have that abundance of supply. And it will really be an effort of cajoling and inviting all the remaining people to come on board.
Thank you, Dr. Liu, and thank you, Dr. Castellani. I think we have all the questions submitted and also on the chat box answer. Looking at the time, right now is 6:06. Thank you everyone for attending this evening's virtual town hall on COVID-19 vaccine. If you have any further questions, you can continue to email APH. We will get back the answers to you as soon as possible. Thank you everyone for attending.